All right, we are live. Welcome and thank you all for joining this edition of DSN's Ask the Expert series. We are continuing our Shedding Light on Dysautonomia campaign as we are getting close to the end of this very important awareness month. I'm Kim Hartman, the Medical Clinical Liaison Coordinator for Dysautonomia Support Network, as well as one of our advocacy team co-leaders. First, I want to go over a few items before I introduce our expert. We have collected questions from our members in our communities ahead of time, and those will be answered after the presentation. The chat feature is enabled for this presentation, and I will be monitoring comments. Feel free to ask questions, and we will do our best to address them throughout the presentation. Information given during this presentation is not meant as a substitute for medical advice. Everyone has varying symptoms, and even though we may have similar forms of dysautonomia, we also have different conditions that may present in their own unique fashion. Now it's time for you to meet our expert. Today we are joined by DSN's Director of Education, Erin Sterling. She has a master's degree in respiratory therapy and is a neonatal pediatric specialist. She's worked and taught as a respiratory therapist for 17 years before becoming disabled. She has continued her education work with DSN since early 2017. Today's presentation is how dysautonomia affects breathing and some tricks to manage some of those symptoms. Erin, thank you so much for joining tonight. We're glad to have you, and this is a hot topic for many of our members. The timing is perfect, especially as we are going into the colder months and respiratory illnesses are beginning to affect many of us. So I'm going to let you go ahead and take it away.
Thank you. Yes, I'm sorry that we are getting started a little bit late. There always has to be that last minute emergency. But yes, so Just Breathe is the title of the presentation, but of course, as many of you know, it's not quite that simple for many of us. And so we are going to discuss a little bit about dysautonomia and breathing. Like Kim said, everyone is an individual, so there's lots of things that can play into breathing beyond dysautonomia, so it's really important that you consider yourself as an individual and your own unique person when it comes to all of this stuff. But we're going to start with how breathing actually works and how dysautonomia can potentially affect it. I'm going to give you the simplest, shortest anatomy and physiology review ever in the history of anatomy and physiology lessons. But I think it's important to understand the process of breathing. So the diaphragm contracts, air moves into the lungs, goes down through all of the airways, through the trachea, through the bronchi, through all of the small airways, eventually down to these little tiny sacs that are filled with air and are surrounded by capillaries where gas exchange occurs. The diaphragm relaxes, air moves passively out of the lungs. So when we're down at that capillary level where the alveoli are, we have oxygen moving from the alveoli into the bloodstream that can be taken to all of the tissues. And you have carbon dioxide that is moving out of the bloodstream into the alveoli where it can be exhaled. The other part of breathing that you need to understand is the part of the nervous system that controls it. You'll notice that the nervous system is divided into the central nervous system and the peripheral nervous system. And we talk a lot about the autonomic nervous system because that's where dysautonomia comes from. And you'll notice peripheral nervous system. Breathing, the respiratory control center, the part that actually tells us to breathe, is part of the central nervous system. So a common question that we'll see is, if you have autonomic dysfunction, will you just stop breathing? The answer to that is no, in a very simple form. Your drive to breathe is a CNS function. But can dysautonomia affect your breathing? Potentially, yes. Part of the brain that controls breathing is in the brainstem. It's in the medulla and the pons, located here. The medulla is kind of the primary controller. It sets the rate and rhythm. There's two different sections of the medulla that control the inspiratory and expiratory neurons. So there are neurons that tell, yes.
Do you want to go ahead and screen share?
Oh, shoot.
No, all of a sudden, I just thought of that. I was like, yeah.
Holy crap, guys, I'm sorry. How did that not happen?
I just thought of that. So go to the green arrow and then you'll be able to screen share.
All right, am I screen sharing?
Yes, go ahead and present.
Gracious. Okay, so you missed some of my pictures. Sorry about that, guys. All right, so we got through the divisions of the nervous system, and we're here at what's controlling breathing. In our brainstem, the medulla, we have neurons telling us to breathe in. There are neurons that then tell the breath to stop and for us to go into exhalation. The pons sets the rate and the depth. It also helps the medulla with the transition between inspiration and expiration. So the two are kind of working together to set both the rate and the depth. And they do that by getting signals back from receptors and sometimes other parts of the brain. So those receptors are called chemoreceptors, which basically means they are special sensitive areas. They're sensitive to changes in chemicals, and then they use those changes in chemicals to send signals to the brain to tell it what to do. You'll notice that the central chemoreceptors is kind of all mixed in here, but central chemoreceptors are located here. This is kind of a blown up version of the respiratory center, the medulla and the pons here. So in the cerebral spinal fluid, there are central chemoreceptors that are especially sensitive to hydrogen ions and carbon dioxide. So the hydrogen ions are going to be kind of your primary drive to breathe while you're resting. And then carbon dioxide is your primary drive to breathe if there are changes. Central chemoreceptors are very responsive to carbon dioxide. Carbon dioxide is an acid. So if you have an increase in carbon dioxide, your blood is going to become more acidic, and that's going to mess up your homeostasis. So the body works very hard to keep that pH in your blood at a very neutral level. So the central chemoreceptors are going to be sensitive to CO2, and that actually changes much faster than any change in oxygen. Most people kind of think we breathe because of our oxygen levels, but that's actually not really true. Although it will speed up our breathing if our oxygen level drops too much. If it does drop, then it is sensed in the peripheral chemoreceptors. And you'll notice that that is located in the aorta and in the carotid arteries, which is baroreceptors are located. If you know what baroreceptors are, those are the receptors that are responsive to pressure changes and what tells our vessels to constrict. So they're kind of the same sort of thing where they're areas that are receptive to changes and then tell the brain what to do. So in the periphery, it'll be sensitive to oxygen and carbon dioxide and hydrogen ions. Other things that control breathing include the stretch receptors in the lungs. They tell the breath when to end so that the lungs don't become over-distended. There are irritant receptors. Those are triggered whenever there is an irritant that enters the lung. It causes the airways to constrict. And then there's other parts of the brain, the higher brain centers, the cerebral cortex, where we carry control over our breathing. And then the hypothalamus, which is just above the respiratory centers, is where you get a reaction from pain or other emotional stimuli. so that the hypothalamus can actually react and kind of like trigger the respiratory centers as well. And a lot of what occurs with the autonomic nervous system is controlled by the hypothalamus. So we'll kind of talk about how that plays into it here in a few minutes. So let's talk about kind of the whenever we feel the need to breathe more. That will happen if we have for some reasons in ventilation where we aren't breathing enough CO2 off. We have a increased CO2 and a decreased pH in our cerebral spinal fluid. You'll also get an increase in arterial CO2. That is going to lead to a chemoreceptor response. The central chemoreceptors are going to mediate 70% of the response, so they're going to be more sensitive to it and are going to kick in faster. And then as a secondary response, the peripheral chemoreceptors will mediate 30% of the response. It'll send a signal to the medulla respiratory center, which will then send a signal to the respiratory muscles to stimulate breathing. You'll start to breathe more, you'll breathe a little deeper, you'll breathe a little faster, you'll exhale more CO2. And as you do that, you'll return your arterial CO2 and your pH back to normal. And so that's how that feedback loop works in terms of keeping you breathing at just the right level. And the same thing can happen with oxygen. As oxygen drops, you'll get a chemoreceptor response that'll send it to the respiratory center, which will stimulate breathing, and so forth and so on. So let's talk a little bit about shortness of breath. This is also known as dyspnea. It's a subjective feeling or sensation, and that can be described in a lot of different ways. Some people will say that it feels like a tightness. Some people will say they can't get enough air. There's a smothering feeling. Their chest is tired, or there's fatigue in the chest. Air doesn't fill their lungs properly. For most dysautonomia patients, this is primarily felt in response to an increased heart rate. Not always, but frequently. That's because anytime, if you think about it, even if you're exercising and your heart rate is increased and you're using your muscles, you tend to feel short of breath at times with that. So think about that. If you have an increase in your heart rate without any exertion, that's going to especially feel out of place. And so we become a little more sensitive to that sensation. It can also accompany chest pain, which might be a result of the coronary arteries receiving less oxygen, whether that's because they're spasming or because there may be a little less blood flow back to the heart, whatever the case may be. And deconditioning will often make shortness of breath worse. Not to where, if deconditioning is the cause of your dysautonomia, but because deconditioning is frequently at least a result of dysautonomia. So the more deconditioned you become, the more that sensation of shortness of breath will kind of kick in at a lower exertion level. And not all shortness of breath is a actual physical reaction or is caused by a physical reaction. It can also have a mental component to it. People with anxiety will feel short of breath. And again, not just necessarily because you're having anxiety and not dysautonomia, but you can get into a sort of cycle where you're feeling short of breath, which tends to make you feel a little more anxious naturally. And then that anxiety will increase the sensation of shortness of breath. And then that just kind of snowballs and makes everything worse. So some of the tricks are actually trying to break that particular cycle that gets going. And oxygen saturations are usually normal for dysautonomia patients. And that's because, again, shortness of breath, it usually comes from three different things. It either comes from the lungs, it comes from the heart, or it comes from a psychological or a mental place. So oxygen saturation is going to mostly be affected if you have lung problems. And because that's not usually the case, dysautonomia doesn't actually cause physical changes in the lungs. oxygen saturation tends to be normal. Severe heart issues, and if things get bad enough with the heart, you can see drops in oxygen saturation, but it's not common. So how does breathing? I'm going to start with the two kind of baddies, the ones that actually really will affect breathing at the central nervous system level. Multiple system atrophy is one, because there's atrophy in the cerebellum, the basal ganglia, and most importantly, the brainstem, which is where that respiratory center is. So because of that, they're at high risk for sleep apnea especially. But there are also cases of respiratory insufficiency or failure where CO2 isn't getting exhaled the way that it should be, and they may need ventilatory support. And they're also at risk for vocal cord paralysis. So all those things have been reported with MSA. The other one is familial dysautonomia. That is the inherited dysautonomia that usually has very severe symptoms from infancy and into childhood. Both sensory and afferent nerves are not developed properly. So that leads to a lot of issues, including severe dysphagia or difficulty swallowing, which leads to aspiration into the lungs, which leads to pneumonia, and eventually chronic lung disease. They actually have chemoreflex failure. Although their central chemoreceptors are usually partially intact, their peripheral chemoreceptors are absent. And so they're not going to respond as well to changes in carbon dioxide or oxygen. They have absent or reduced lung stretch receptors. They have spinal deformities that lead to restrictive lung disease. And they're at very high risk for sleep apnea that can lead to death. So for familial dysautonomia especially, it's actually not uncommon for respiratory issues to lead to death. But otherwise, most other forms of dysautonomia, these are both primary dysautonomias. Most others that are secondary do not have those really severe effects on the respiratory system. For dysautonomias with primarily overactive sympathetic drive, we kind of think about the sympathetic drive, it speeds up our heart rate. It dilates the airways, which means that it opens them up. Metabolism increases. It's the whole fight or flight, get ready to run sort of response that you have. So it doesn't directly affect your breathing, but it does indirectly affect it, because part of the sympathetic response is that metabolism increases. When that happens, your CO2 production increases, and you get that whole flow that we just talked about a few minutes ago, where the pH decreases and then your respiratory rate and depth increases. So again, you're feeling like I'm breathing deeper, I'm breathing faster. It kind of adds to that that sensation of shortness of breath also. And then there's a certain amount of stress interaction on the respiratory centers if adrenaline is high, that's triggered through the hypothalamus. And then for those that hypotension stimulates the baroreflex. Remember, we said that that was the part that senses pressure. There's some suggestion that there's an effect on the respiratory centers of the brain by the baroreflex as well. It's separate from the chemoreceptors, although other theories suggest that there's a sort of crosstalk between the two. What happens is that, again, you get a hyperventilation, not so much in rate, but primarily in terms of how deep you're breathing. And that was studied primarily in animal trials, but they have also done a small population human trial as well. But it's kind of almost more of a theory. They don't completely understand exactly how hypotension is affecting the respiratory centers, but they know that it does to a certain extent.
Erin, can I interrupt for just a minute? Sorry. We've got a question that came in. I was on oxygen for 3 years without a lung disease, but I was diagnosed with asthma. I was told the desaturation was dysautonomia related, but never could find reading material.
Yeah, and I mean, something like that is going to require the physician's explanation as to why they thought it was dysautonomia. Because that's kind of impossible to be able to answer from a standpoint of not knowing all of the
Patient
different
history.
Yeah, there's a lot of factors that can go into it. So on an individual level, I'm not sure. If you're having drops in saturation and your doctor thinks it's because of dysautonomia, they should be able to explain why they think that to be so. Some people who are on oxygen are not on oxygen because of respiratory issues, but because of heart issues. Like I said, if the heart issues are severe enough, it can potentially affect oxygen saturation. It's just not very common in dysautonomia patients. But again, it could potentially depend on what form you have as well. So that would have to be a question that would go back to them.
Thank you.
I don't know if that helped very much, but so what is out there in terms of understanding shortness of breath and dyspnea in patients? The studies are few and far between. They're very small. It really hints more at theories than it does any kind of valid data at this point. But I'm going to share a few of those studies with you, kind of that just sort of explain some of the things that are happening that could potentially cause people to hyperventilate or to feel short of breath with their, and these were actually all done with POTS patients. And I know the question always goes back, why is it always POTS? And that's because it's the most common form of dysautonomia. Although, at least in the next study, the same would apply to people with hypotension as well. But with this one, this was done in 2004. It was just 20 POTS patients, and they compared them with 10 healthy controls. Out of those 20 POTS patients, 10 of them had hyperventilation with a decreased CO2 level, which is important because you can breathe fast and not necessarily have a decreased CO2 level. So they were actually looking at something that was true hyperventilation during the tilt. And what they noticed was that it came from the depth of breathing rather than the rate. All of them had blood pooling in the abdomen, but the ones with hyperventilation had significantly increased peripheral vasoconstriction. The ones that had hyperventilation also had acrocyanosis. That meant they had blue or purple extremities, and mottling with cold extremities, which they felt was due to decreased peripheral blood flow. But the way that they did their measurements and the way that they came out with their conclusions, it left them with questions whether POTS was causing hyperventilation or whether hyperventilation was actually causing the POTS. And I'm going to come back to that in a second. But at the very least, what they were noticing was that there was definitely peripheral vasoconstriction in POTS patients that where they were hyperventilating. Looked at cerebral hypoperfusion and noticed that this is a very small study, but they took only 11 POTS patients that complained of dyspnea as their primary, like, chief complaint. Shortness of breath was something that, like, really, really bothered them. And then they compared those to 10 healthy controls. And what they found was that blood pooling, which happens in most POTS patients, but in all of these dyspneic POTS patients, the blood pooling resulted in reduced cerebral blood flow, which kind of makes sense if you think about it. If you're standing and you have blood pooling, that blood is going to your extremities, and usually you have an increase in kind of abdominal blood pooling as well. And so that blood isn't returning back to the heart, and it's not going to the head. And when you have a reduction in cerebral blood flow, that is actually stimulating the central chemoreceptors to induce hyperventilation. Again, mostly depth, but some rate. So even though there wasn't actually a change in CO2 that caused that stimulation, it was just the fact that the brain recognized that it wasn't receiving as much blood flow and said, hey, if I'm not getting as much blood, I better speed up my breathing so that I can actually get some more oxygen here. And it's important to note, though, well, one, in this case, they found that a decrease in CO2 came after the reduction in cerebral blood flow. So they felt that the cerebral blood flow was the main cause of the hyperventilation. But it's also important to note that a decrease in CO2 is also going to cause constriction in blood vessels in the brain, which when you already have reduced cerebral blood flow, that's not necessarily a good thing for us. And then they believe that could potentially lead to some of the brain fog that we experience, and that lightheadedness and that dizziness that all kinds of plays into it. But what it's also going to do is stimulate sympathetic reaction because it's going to want to get more blood flow going. So then the group that did the first study, they did another one. And this time they took 58 POTS patients and 16 healthy controls. And out of those POTS patients, 14 of them hyperventilated when they were tilted. And they got the same thing where the hyperventilation occurred with the reduced cerebral blood flow. As cerebral blood flow decreased, hyperventilation increased. But the really interesting thing that they did was that they had the patients breathe supplemental carbon dioxide. Remember the first time they weren't sure kind of what was causing that. So they had them breathe carbon dioxide, and they found that by doing that, that they were able to get their breathing, their heart rate, their cardiac output, their systemic vascular resistance, it all returned to the same level of healthy control subjects, which, and this is, you'll note, a new study. So this is something that is going to need to be verified and everything else, but their conclusions are that hyperventilation in a subgroup of POTS patients was caused by decreases in cardiac output, blood pressure, and cerebral blood flow, but that they could actually be normalized, that the postural hyperventilation was what actually caused the excessive tachycardia. And so if the postural hyperventilation is causing excessive tachycardia, that's actually what's causing the POTS. So that there may be a group of patients where hyperventilation is a cause of their POTS, not a result of it. Now, that's saying that it's hyperventilation, not just hyperventilation because you're just breathing faster for no reason, but hyperventilation because you have blood pooling and that decrease in cerebral blood flow. So those are a few of the theories in terms of how blood flow and that decrease in blood flow will cause ventilation or hyperventilation and cause that kind of shortness of breath that you feel. The other thing that I'm going to talk about in terms of shortness of breath is going to be along the lines of mast cell disorders, which is not a dysautonomia itself, but a common coexisting condition. And it can frequently affect breathing as mast cells play a role in allergy response. Some of that allergy response, and this doesn't happen for everybody with mast cell, but for some people with mast cell, it can cause bronchospasm or tightening in the airways, or anaphylactic shock in severe cases. I think the other person was talking about reactive airway disease. And so it may not be true asthma, but it's sort of a reactive airway type of situation. So we're going to talk a little bit about pulmonary diagnostics and how they can kind of look at whether the issues are coming from the lungs or from something else. In terms of seeing a pulmonologist, you should see one if shortness of breath is one of your chief complaints, just because it's good to make sure that it's not some other issue that's completely unrelated to dysautonomia. If you have shortness of breath unrelated to cardiac or blood pressure symptoms, especially, because that would suggest that there may be something else playing a role in it. If you have a decreased oxygen saturation, they need to be aware of that because it doesn't typically go with just dysautonomia. If you have other respiratory symptoms, such as wheezing or other abnormal breath sounds, coughing or mucus production, if for any reason it is unclear whether issues are coming from the lungs or from the heart or other autonomic issues, your primary doctor may order some of the respiratory tests initially and then refer you to a pulmonologist if needed. If it's not a pulmonologist, again, if mast cell is more suspected, then they may send you to an immunologist or an allergist as opposed to the pulmonologist. It's kind of going to depend on what's showing up. And your cardiologist can also order some of this stuff. Pulmonary function testing is probably the one I'd see talked about the most on groups. There is more than one type of PFT. So it depends on what type of PFT they do as to what they can actually look at. But on all of them, they can look at lung volumes and airflow, and they can determine whether obstructive or restrictive lung disease is possibly present. I say possibly present because this is just one tool in the toolbox, multiple diagnostics to really come up with a specific diagnosis. Obstruction means that you can't get the air out. So asthma, COPD, a reactive airway disease, those are some examples of obstructive lung disease. Restriction means you can't get the air in, and that could be coming from inside the lungs or it could be coming from external pressure on the lungs. So things like the spinal deformities in familial dysautonomia, but EDS also, there's some forms of EDS that have curvatures in the spine. So that might also cause restriction. If your spinal cord is not straight, if it's crooked, it kind of throws off the rib cage and everything else in the way that it's pressing against the lungs. So if it's pressing against the lungs, you may not be able to get air in fully. Another example, even obesity can cause a certain amount of restriction. So once you find out that you might have restrictive lung disease, you then have to kind of find out what's causing the restriction. Is it coming from outside the lungs or is it coming from inside the lungs? The PFT can also, if you have obstruction, it can test your response to bronchodilators. Bronchodilators only work if you have obstructive lung disease. We'll talk a little bit about that more later too. Whether you have reactive airways or asthma, there's a give to you that if you have asthma or reactive airways, it will induce bronchospasm in you. If you don't, then it's not going to have any effect on you whatsoever. And then the last thing that they can possibly look at, and they don't do this with most patients, it really kind of depends on your overall clinical picture, but they may look at diffusion capacity, at whether gases can move from the alveoli into the capillaries. So if you do have decreased oxygenation, then they might do this test so they can see whether or not it's an issue of being able to actually move the gas from your alveoli into your capillaries. Whenever you do a PFT, they repeat it 3 times each test to ensure accurate numbers. When you do the test, it's very important that you do your best every single time that you do the maneuver. It has to be within about 5%, the numbers. Even if you have lung disease present and you do poorly with it, you'll do poorly consistently, and it'll be the same numbers will show up 3 times. If the numbers are wildly different, it indicates that each of the efforts was not the best effort that you could do. So it's really important to put that best effort into when you do the pulmonary function testing. Otherwise, they won't be able to really get a good, accurate graph and numbers and diagnosis there. Some additional tests would include an arterial blood gas. They draw that from the artery. They may do that with the PFT, or they may not do it at all, depending on your other tests. They do it to look at pH, your carbon dioxide, your oxygen, and a bicarb, which is, for you guys, not nearly as important. They may do a chest x-ray or a CT scan if warranted. That kind of, again, helps them figure out what's going on in the lungs, if there is something there. And the last test here is something called a 6-minute walk test, which measures functional exercise capacity. It's kind of the easiest way to look at what your capacity is for activities of daily living. How far you can walk in 6 minutes. So what they'll do is a blood pressure, heart rate, and oxygen saturation. And they'll measure it before and after, as well as having you rate your shortness of breath and your fatigue. You'll walk for 6 minutes. They'll gauge how far you've gone. You may be asked what kept you from going further if you didn't go kind of what you would have been expected to go. The issue with it is that it doesn't distinguish or diagnose why you may have decreased exercise capacity. It only kind of shows that you do. So they may follow it up with a cardiopulmonary stress test or a CPET, which is this next bit. Exercise capability is determined by 3 things. It's determined by pulmonary gas exchange, how well you can move oxide in and out of the lungs, your cardiovascular ability, how your heart and your blood pressure do, and your muscle metabolism. So it looks at how the lungs, heart, and muscles are working together and independently, and can help determine why the shortness of breath, particularly with exertion, is occurring. So they hook you up to a face mask where they monitor oxygen, carbon dioxide, your respiratory rate, and your pattern. The EKG will monitor your heart rate and rhythm, a pulse oximeter to measure oxygen saturation, a blood pressure cuff. And you'll notice that she's on a bicycle. They do that on a bike so that more patients are able to tolerate the test. And it actually gives them some pretty good information in terms of why a person may feel short of breath. Even if it's not completely on exertion, but it definitely helps them with exertion. And there's a lot of studies out there that have shown that POTS patients in particular have a decreased exercise capacity, which is not easily improved, except beyond just reconditioning as much as possible. Pulse oximetry. So a lot of people use them for home monitoring. But it's important to be aware of what you're measuring, their limitations, and how to know if it's accurate. So what you're measuring is heart rate and oxygen saturation. Normal saturation is 97 to 99%. What that's measuring is the amount of oxygen is in your hemoglobin, how saturated your hemoglobin is with oxygen. So it's okay to be, 100% is fine. A little bit less than 97% is fine. But 97 to 99 is about, what we say is absolute normal. When you are measuring, it is important to allow at least several seconds for the reading to stabilize. You don't want to put it on your finger and look at that very first number that comes up for either your heart rate or your saturation. You gotta kind of give it a moment for it to settle. The other thing is that you really have to be still. Most have difficulty measuring during movement. So if you are trying to find out what your saturation is while you are moving around, what you want to do is go ahead and move around, but then stop and then put the pulse oximeter on, let it stabilize, and then get your reading. It's not going to change drastically. If you're moving and it's dropping instantly as you're moving, it's more likely due to motion artifact than anything else. A really sudden drop is not really physiologically possible. So let yourself move and then check it at rest. Make sure your hand is warm. It's going to have difficulty measuring if your hands are cold or you have poor perfusion, which for us, make sure your fingernails are free from nail polish. That will affect the reading, particularly if it's black or blue or green, but I have had problems with it even with different shades of red or purple. So it's just better to, if you're going to measure it to do it on a finger that is nail polish free. And also fake nails can throw it off too. Other limitations can include hypotension. If your systolic pressure is less than 80, so I mean, you have to be pretty significantly hypotensive, but at that, it's no longer accurate. And you may have low oxygen levels at systolic pressures less than 80. It's just that you can't necessarily use the pulse oximeter to give you an accurate reading at that level.
Erin, I'm gonna,
Yes.
sorry.
Okay.
We just had a question come in. Is there a pulse ox that you recommend that's accurate?
No, not really. The ones that are affordable are all kind of the same. There's a lot of like really, really cheap ones out there, and they're all basically the same. You're not going to get really until you start getting into significant medical grade. And even then, they have the same limitations that the cheap ones do, really.
The ones that actually are the ones that you're able to see the pleth or the waveform on, those ones at least you can tell that you're getting a little bit better reading.
They are, yeah. I mean, they will typically, it gives you something to go by.
Right.
But even the ones that have like the pleths are not always like, you could think that you have a fairly good pleth signal and it not be the best pulse oximeter. Right. Not bad either. It's just that they're going to all have a very similar limitation to them. It's kind of like blood pressure cuffs, really. I mean, they're all kind of created equally in terms of that they all work in the same way. But some of the better, like the medical, have it where like motion artifact affects it a little bit less. But even those, we have to be careful about measuring while somebody's moving around. Let's see. So we're at anemia. With anemia, readings can be falsely high. Again, remember you're measuring how saturated the hemoglobin is. With anemia, all of your hemoglobin could be very well saturated, but you just don't have enough hemoglobin. And when you don't have enough hemoglobin, that in itself can actually make you feel short of breath because level may actually be low, like the actual amount of oxygen in your blood can be low, even though your saturation is normal. So that is something to kind of keep in mind. Now that typically happens with, I mean, pretty significant anemia. We're not talking, mild anemia here, but if you have significant anemia, which I know some people do, if you have more shortness of breath, that could be a reason why. And then bradycardia and irregular also. Yeah.
I just wanted to catch you before you change slides. If we think we have Raynaud's syndrome, will we have issues with taking a pulse ox at home?
Yes. If you are actually in an attack, yes. If you are not in an attack and your hands are warm, you're okay. But if you actually are in Raynaud's attack, then no, your pulse oximeter is not going to read accurately.
Thank you.
Yeah, warm your hand up for that one.
Exactly.
Run it under some warm water. Put a warm washcloth if you can get it out of that Raynaud's attack. That's what you want to do, or go to a different extremity.
Get the color back in your hand.
Yes, make sure the color is back in your hand before you do it. If you have bradycardia, it's also going to have difficulty getting measurements. With really severe bradycardia, you can have decreased oxygen levels. Can, not always, but can. But again, it's pretty significant bradycardia usually. But at any rate, you have to kind of take whatever result that you get with a grain of salt, and that it's not necessarily going to actually be the level that you are. The same thing happens whenever a person has a saturation of less than like about 70 to 75%, the pulse oximeter is just no longer accurate at that point. It's not, I mean, their oxygen level is still low, but it's just that we can't take that as an accurate number. And at that point, we'd have to get a blood gas in order to determine what their actual oxygen level is. So there's definitely limitations to using them, and to keep that in mind when you're using it. So one way to check the accuracy is to measure your pulse manually and check it against the pulse oximeter. In a situation that still may not always catch errors, but certainly if you check your pulse manually and your pulse is 100 and it's only reading 60 on your pulse oximeter, you can't trust what the numbers are. If you get really crazy numbers, consider how you're feeling. If it's reading 70% and you don't really feel that symptomatic, it's probably an error. If your numbers are off, then and you have symptoms, record your symptoms along with your numbers, and take it back to discuss with your physician. And like I said, remember that a very rapid change is likely an error. It takes time for changes like that to occur. It's important to note that although normal is considered 97% or greater, if you're a long-term smoker, you may have a normal saturation of 93 to 95%, or even less if you have significant lung disease. So that's something that you would need to discuss with the doctor, the pulmonologist. If you're experiencing low oxygen saturations, especially with symptoms, it's important that you seek medical attention right away. And I think there was some questions about, what a magic number there. It's really not a magic number so much as how you're feeling, what you're like. If you have something that would normally have you run a little bit lower than the average person, but especially symptoms, and if you're running, low 90s into the 80s, something where you're really experiencing symptoms, especially if it's new for you, you really want to make sure that you get that taken care of right away or seen right away. So now that we've talked about all that, how can we fix it? Well, in a lot of ways we can't fix it, because again, it's that sort of sensation that our brain sometimes makes us feel even when there's absolutely no reason for us to feel it. A lot of times it's tied to our heart rates or our blood pressures. So if we can get those under control, it will certainly help breathing most of the time, but not always. There's still plenty of people who say, I'm still short of breath, even though my numbers are okay. And in those cases, I think a lot of times it's just our brain's sending us that sensation when there's really no need for it. And so some of the things that we can do are more to kind of help you reset, to calm your breathing, to help you catch your breath, or even just to relax. The goal of most breathing techniques is to use your higher brain to take control. So when you got other things that are influencing it, even if your hypothalamus, if your areas, your autonomic system is influencing it, there are ways to kind of take control of that and pull it back a little bit. Typically, techniques are best practiced when you aren't having shortness of breath or other symptoms, at least initially, because some of them take some practice to get used to. And once you have them mastered, they'll come more naturally to you when you do need them, and you won't even have to really think about it. You'll just kind of automatically start breathing in a different way. In addition to helping as a stress relief, they can also have an impact on heart and blood pressure, not just in the short term, but in the long term as well. Not all breathing techniques are good for every form or every individual, though, so keep that in mind as you try them. But one of the safer ones and the easiest ones is abdominal breathing. It's also known as diaphragmatic breathing. We use it a lot with patients with lung disease, but it has a lot of additional uses and benefits. Actually, there's a lot of yoga techniques that use it as well. It relaxes you in general. It stimulates the parasympathetic system and decreases sympathetic response, something we usually want. It reduces pain. In fact, they will also teach this to cancer patients. And it tones core muscles and improves posture. And toning those core muscles can help, especially when it comes to that abdominal blood pooling. You can get those core muscles a little bit more toned. You can sometimes prevent some of that. So the main thing with abdominal breathing is that you want to make sure that the breaths are slow and unhurried. And they can be done either laying down or seated. So if you're having trouble sitting up or feeling short of breath sitting up, you can try laying down and doing them as well. You can see this lady. So she's got one hand on her chest and one hand on her belly. And we're going to take a slow breath through your nose, and you're going to push your abdomen out while you do it. It doesn't have to be a very long breath. About 2 seconds is all that it really needs. You should feel the hand on your abdomen rise, but the hand on your chest should remain relatively still. And then when you exhale through your mouth or your nose, whichever one is more comfortable, you're going to pull your abdomen in. And again, about 2 seconds. Your hand on your abdomen should go down. The hand on your chest should remain relatively still. So basically, the hand on your chest is just to make sure that you're not really moving your chest that much. Most of the work needs to come from your belly. So it should push out when you breathe in, and you should suck it in when you breathe out. And it feels a little odd at first, and that's why sometimes the hands help. But after you've mastered that technique, you won't need to use your hands to help as much. And like I said, you'll kind of sometimes even go into that form of breathing automatically when you become short of breath. Ratio breathing is a little bit different. It takes a little more practice. It may not always work. But the goal is to increase the depth of breathing, potentially stimulating the vagal nerve and slowing the breath down. If you have neurocardiogenic syncope, it'd be the best one for you to use. It just depends on whether or not deep breathing is a trigger for you. If it is, this probably isn't one for you to do. But otherwise, it's something, especially if you have tachycardia, this can be a good one. If your symptoms increase, you could always try using a lower inspiration to expiration count. That's what ITE is. Normal IDE is 1 to 2 to 1 to 3. It basically means for however much time we breathe in, we spend twice as long exhaling, or 3 times as long exhaling. But it's usually pretty quick, right? You do about a second in and maybe 2 seconds to 3 seconds out, and not much more than a second. Ratio breathing may use the same, like the normal ratio 1 to 2, but just for longer periods, or we might change it to a less than a 1 to 2, and we can add a breath hold, or we can do it without a breath hold. It just depends on your own comfort level and what works for you. So technique 1 uses a slightly longer 1 to 2 ratio. And I have these shown where it's kind of working it up in steps and then working back down. You don't have to. You can stay at one level for the whole time until your breath is kind of back under control. Or you can ramp up and then stop, or you can ramp up and then ramp back down. It's really kind of all in what you want to do. You can kind of customize these quite a bit. The goal of it is really just to make it so that you are focused on the breath. That actual physically counting the breath is causing that voluntary control to take over, and your involuntary control will take less and less and less of the breath away from you. So with technique 1, for example, you might inhale for 3 seconds and then exhale for 6 seconds. You might do that for several breaths. You may notice that the breath starts before you've gotten to that 6 count. If that happens, that's okay. Just start it again. Okay, I'm inhaling for 3 seconds, and I'm going to try to exhale for 6 seconds. And if you get to the 6 seconds, great. If not, if the next breath starts, just start it over again. And just keep doing that, but keep trying, keep pushing to get to that 3 second to 6 second hold. you may find that as you do that, the more you do that, the easier it will become. You might only be able to do 3 to 6 at first, and then you can go up to 4 seconds and then exhaling for 8, inhaling for 5, and then exhaling for 10. I've actually never mastered that one, but it's possible, I am told. So you could always give it a try. Technique 2 uses a less than 1 to 2 ratio with a breath hold. Although again, if the breath hold is not possible, you don't have to do it. But this requires you to inhale for 3 seconds, hold for 3 seconds, exhale for 4 seconds. Inhale for 4 seconds, hold for 4 seconds, exhale for 5 seconds. So the exhalation period is not quite as long. I find this one a little bit easier to do than technique 1 personally. And the breath hold often helps me kind of reset. If I don't do the breath hold, then I tend to, my breaths are all over the place, at least at first. So that breath hold kind of gives me that extra bit of voluntary control. So again, you can kind of walk it back up and then walk it back down. But everything is at your own comfort level. So stay wherever is most comfortable. If you can't walk it up, that's okay. It's just something that you can kind of play around with. Again, the goal is really just to keep that count in your head. You can also make it a 1-to-1 ratio. So you could inhale for 3 seconds and exhale for 3 seconds. Inhale for 4 seconds, exhale for 4 seconds.
Erin,
So
we've got another question that came in.
Yeah.
What are your thoughts on biofeedback therapy?
It can be very helpful for some. Not everybody, but it can be. It's usually worth a try because it's pretty easy and it doesn't require, it's not invasive, it doesn't require anything significant from you other than just the effort in trying it. So it's usually a good thing to at least give a go. It depends on, I don't know, different people do it in different ways. So it depends on the practitioner as well and who is actually doing the biofeedback with you. I like psychologists who deal with biofeedback probably more than anybody else, but that's just me personally. I know there's other practitioners out there who do that sort of thing.
Thank you.
Sure. And yeah, biofeedback is one of those things, and it's kind of this kind of goes into biofeedback a little bit, at least to some degree. This is kind of biofeedback without actually seeing the results of it necessarily. Is just simple mindful breathing, especially when it just seems like it's impossible to properly control your breathing. If I just get to if I'm in a place where my breath just doesn't seem to be under my control, it just wants to do its thing, I will just simply be mindful of the breathing. And in doing so, that can actually help relax you. So it doesn't involve anything but paying attention to the breath. You don't need to try to change it, but you do need to try to view it without emotion or distress, which is a little bit trickier. But it does come eventually. Are able to just kind of say, okay, like I'm breathing, I might be breathing fast, I might feel a little air hunger, but trying to kind of reassure you and not to focus on the sensation itself, but rather focus on the breath. Think about the breath as it's going into your lungs. Think about how it feels, the air moving through your airways, and then how it leaves your lungs. If you're focusing only on the breath, it'll start to pull your mind away from the sensation of that shortness of breath. A few added tricks that might help slow it down or relax you is to think about the breath circulating around your heart as you breathe in. You're a little tachycardic, or if you're having some chest pain, think about the breath coming in, circulating your heart, kind of soothing it, and then exhaling. If you can get to it, sometimes it will also help to add a soothing color to the breath. Think about it going through your body. Like once you really get your breath slowed down, you can actually kind of think about the breath moving through your whole body. Think about colors like going through your body, and then think about it leaving your body. And you'll find that your breath naturally starts to slow down when you do that. Now this one I came across kind of last minute, and I thought was interesting because I had not come across it before, where they were using inspiratory resistance to decrease tachycardia in POTS patients. This was done at Vanderbilt. They used an inspiratory resistance device or a dummy device with 39 POTS patients. An inspiratory resistance device is just basically something where when you breathe in, there's a little bit of resistance that keeps you from easily breathing in. And so you would think, well, that can't be good because that's going to make it feel harder for me to breathe. But it actually, and I can't really go into all the hemodynamic effects of it because it would be kind of a little too hard to explain. But what they found was that after 10 minutes of being upright, using that inspiratory device decreased both heart rate and improved stroke volume, meaning that it helped the heart pump more effectively. So I'm surprised that this hasn't necessarily showed up in treatment stuff yet, or is not in the common counter maneuvers that we see for POTS patients. But you can get the same type of effect just by pursing your lips when you breathe in. Now, I have not tried this one yet. I keep waiting to be short of breath and tachycardic, but my heart rate's been pretty well under control the last few days. I haven't been able to test it. So somebody will have to give it a try. Test it when you are upright. So this is only going to help you when you're upright. Purse your lips when you breathe in and see if that reduces your tachycardia at all. I'm very curious on this one. I'll have to add my own comment whenever this, I get to trial this myself. And the last thing I wanted to talk about is respiratory medications, because I know that there were some questions when it came to medications and when to use them and that sort of thing. So respiratory medications, first, I think I have to be very specific about the fact that respiratory medications are used specifically to treat things that are happening in the lungs. If your shortness of breath is not coming from inside the lungs, then respiratory medications are not going to help. So if you're using respiratory medicine and you're not finding any relief from it, it's probably because it's not because of the lungs. Bronchodilators are the short-term rescue medications, your albuterol and your Xopenex. They do take time to work. I mean, normally you'd start noticing a difference in about 5 minutes, but 10 to 15 is when you're going to start noticing the peak effect of them. Albuterol can be kind of a rough one because it's a sympathomimetic, so it's going to be stimulating your sympathetic nervous system. So it's kind of a double-edged sword there sometimes. So it's possible that that sympathetic reaction that you're getting from your albuterol may end up playing into some of the shortness of breath that you feel from that triggering. But normally people wouldn't necessarily experience that without dysautonomia or a overactive sympathetic system.
And Erin, by that you mean, I just wanted to clarify, by that you mean like tachycardia and things.
Yeah. Yeah, I mean, people without dysautonomia will get tachycardia from albuterol.
Correct.
So, but they won't necessarily have the same level, because remember I talked about how that overstimulation of the sympathetic nervous system will kind of kick in that sensation of the shortness of breath. For us that may already have an overactive sympathetic system without the albuterol, when you add that into it, you're going to get that extra kind of kick to it. So
right.
It's possible, and again, I'm kind of throwing out a theory here based on my own knowledge of how it works, and how that sympathetic center can kind of kick in to stimulating breathing and that shortness of breath sensation. Why some people who are using their inhalers may still have shortness of breath or may even notice that it's worse. There's some longer acting bronchodilators that are usually combined with steroids. And then you have Atrovent, ipratropium bromide. Sometimes they add that to your rescue, but we use it more commonly in lung disease patients. But I know sometimes they use Atrovent in place of albuterol or Xopenex if people really can't tolerate it. But all of those drugs are going to help smooth muscle that can become constricted with things like asthma or reactive airway disease. Usually the people that are on bronchodilators are either people who have asthma or COPD or have reactive airway from mast cell activation. So those are typically the people that are going to have bronchodilators. Corticosteroids are drugs that are going to reduce inflammation in the lungs. They work directly on them, so there's fewer side effects. Again, it's a maintenance drug. It has to be taken routinely for it to work. But it's only going to work if there's actually inflammation in the lungs. And then the last one is a leukotriene modifier. I guess, again, you can see that a lot with mast cell patients. The singular being one of the ones that's most commonly used. That's going to help with the allergy response that can lead to breathing issues. So those are kind of, I think, the more commonly seen respiratory medications that people are on. It's just that it's just not going to help if it's not respiratory related or not lung related. So with that, if there are additional questions, Kim?
It doesn't look like there's any more that have come in, but I definitely have that list. So if you want to stop screen sharing so we can see you go, now I'm going to make it so that it'll go. There we go. Okay, so it should go back and forth between us now, I think.
Okay.
Potentially. Okay. When my temperature goes haywire, I gasp for air. Is my rescue enough, or should I do a breathing treatment?
So again, that kind of falls back to the last slide. Since temperature regulation shouldn't really have anything to do with whether your rescue works or not, it shouldn't matter which one you use. It probably isn't going to help either way, unless you're having some type of bronchoconstriction along with the temperature going haywire, in which case, in terms of NEBs versus MDIs, they should work the same. Everything suggests that they do, as long as you take them the correct way. So if you're taking your inhaler, where you're taking your inhaler and then you're taking a puff and you're waiting a minute to 5 minutes and then taking your second puff, you're doing it with a spacer, which I know nobody does, then you should have the same basic effect of the two, between the two.
Let's see. I know we had a lot of questions. A lot of them you covered in the presentation. So I'm just trying to I've been trying to go through and sort so that we're not kind of repeating here. Let's see. How does, I know that we talked about blood pooling, but how does blood pooling affect breathing and pulse oximetry readings?
So that's one thing that I did not mention with the studies. So blood pooling, I said the blood pooling, because it reduces that cerebral blood flow, and it will cause hyperventilation, where you have more of an increase in depth of breathing rather than rate. But what they found when they did those studies is, even though they had blood pooling and they had the hyperventilation in some of the patients, pulse oximetry was the same. It was normal in all patients. Pulse oximetry did not decrease in any of the patients at all.
Perfect.
So in effect, there is no effect on pulse oximetry.
Okay, great. Let's see here. This one I thought was interesting. And I know that a lot of dysautonomia is thought to be a cause or be related to Ehlers-Danlos syndrome. But this member had put that she has episodes of air hunger. They last for a day or more, or for hours at a time. Her oxygen saturation dropped into the low 90s, and the only trigger she could identify was that storm fronts were pending. Can barometric pressure impact us in that way?
It should not impact pulse oximetry in any way. It must have just been a coincidence in terms of exactly what was occurring there, or there's a different physiological mechanism that's causing saturations to drop there, but barometric pressure is not one of them. And even Ehlers-Danlos syndrome by itself would not necessarily cause days of air hunger or pulse oximetry to drop. So that's something that would need to be investigated further.
Correct. Okay. Let's see here. I was an athlete until all of a sudden I came down with asthma 5 years ago, eosinophilic asthma. No rescues or my 4 daily inhalers or nebulizers work to help. Prednisone is a lifesaver, but I can't stay on it. I've got a clean heart bill of health. How do I approach my pulmonary doctor with the idea that I want to know if I have dysautonomia? I have all these other symptoms too.
Okay, so this is somebody that doesn't have dysautonomia necessarily, it sounds like.
Correct.
Yeah, I mean, eosinophilic asthma is an allergy type asthma. It may be that I don't know what other medication you could be on in terms of actually helping with the eosinophilia. Medications that are more like the leukotriene inhibitor, like the Singulair, would probably be more beneficial, or you may need that in addition to having your rescue inhalers. Yeah, I mean, in terms of the eosinophilic asthma, it doesn't really necessarily connect to dysautonomia, so it really depends on what other symptoms you would be having along with it. But talking to them, primarily if you're having changes in heart rate and blood pressure, that would typically be probably what you'd want to talk to your pulmonologist about if you thought it could be related.
Okay. I have exercise-induced bronchospasms and sometimes anaphylaxis. The problem is that it comes on without warning and is delayed. So I don't know when I have overdone it. Are there any early warning signs to look out for that I may be missing?
Not necessarily, but if you're exercise-induced asthma, you should be taking your rescue inhaler prior to exercising. Depends on what you're on, but taking it 15 to 30 minutes ahead of time before you exercise can help prevent an attack from happening in the first place. In terms of the anaphylactic shock, unfortunately, that one is one that you just kind of have to always be prepared for. You can't really prevent that one, but the asthma you can to some extent.
Okay. Let's see. How does this we kind of hit on? How does dysautonomia affect our lungs and oxygen levels? My oxygen saturation has been dropping from 98 to 70 to sometimes 79% when I move around, and it's been suggested more so related to the POTS than a true lung issue. I will almost black out, feel like my chest locks up, and get a barking cough. Also, can it mimic asthma? I've been told for years that I have copycat asthma, and while there seems to be a reactive airway component, it's not true asthma, although they do have CVID.
Okay, there's a lot to unpack there. I'm trying to think. Give me the first part of that again. I couldn't hold that all in my brain.
Yeah, I know. And actually, what we can do is I
think,
can email.
okay, I kind of remember what I was going to say. I was going to say that there's, like I said, dysautonomia doesn't actually, it doesn't change the structure of the lungs or really the physiology of the lungs or how you breathe, how you exchange oxygen. If you have a reactive airway component, though, because dysautonomia won't cause the barking cough either, but some type of asthma component could, or reactive airway component could. So this is one, again, another one where you need to see the pulmonologist to try to find out exactly what is going on with that pulmonary component. Whether they could do that test that I mentioned before is called a methacholine challenge. Whether they could try doing that to see if they could bring on the bronchospasm. Maybe that is something that you are experiencing. POTS in itself shouldn't cause the barking cough, and POTS really shouldn't cause the drop in oxygen saturation. So that is very likely coming from a secondary condition. But like I said, we see that a lot in people with POTS plus mast cell activation. So if that's not something that they've looked at in you, and you do have a reactive airway component, that may be something that they want to address further. There we go. trying to hold that all in my brain here.
Yeah, it's kind of a long one. So I'm going to do one more question here, and then what I'll do is email all the questions to you, and then we can go ahead and make up a document and post on both the public and Divas and Dudes, as well as Twitter. And that way, just because we're, kind of going a little long-winded here, and we don't want people to get bored with us. So we'll do one last one. This one I got came in an email this afternoon. I have orthostatic intolerance, but not POTS, following radiation and chemo treatment to my neck and chest 10 years ago. I struggle constantly with shortness of breath ever since my symptoms showed up 5 years ago. My local doctor says shortness of breath is not a symptom of dysautonomia. Can you explain how shortness of breath fits in with dysautonomia? Is there anything I can do to improve my breathing? I can't exercise, and I'm also heat intolerant. Thanks. Okay. And I know a lot of this kind of fits into what we've already covered.
Yeah, a lot of it would be kind of repeating some of the things that I've said before. Yes, there are some doctors who will say that shortness of breath is not a symptom of dysautonomia. And they say that, I think, mostly because there's not typically lung components to it. But again, I mean, I think what doctors forget too is that there are more components to shortness of breath than just a lung component. People can be short of breath for more than one reason, and that sensation can be there for a multitude of reasons. So, and there are parts of dysautonomia that will stimulate that sensation. And in terms of trying to get that back under control, a lot of those breathing techniques that I kind of shared don't require any exercise. So maybe give those a go and see if any of them help.
Sounds good. I did see one more question here just on our chat. Someone said, great information. Is there any reading material that you would recommend? And I know we've got some information up on our website.
In terms of actual breathing material, because there's so few studies out there, it's a little difficult to say, yeah, there's a whole lot of reading material on it. It's not. It's few and far between. And even what's there, like I said, what I've shared with you are such small studies that they're can only kind of be taken with a grain of salt. They're more theories at this point than anything else. They need larger population studies in order to really validate them as really evidence-based. But I think that what can be really helpful for a lot of people is not necessarily just looking for information on breathing with dysautonomia, but just on breathing in general. The same techniques that we use for breathing with lung disease patients can help with dysautonomia patients. So if you're looking at different breathing techniques like the abdominal breathing or mindfulness or that sort of thing, a lot of meditation books have stuff like that. And there's a lot of like techniques within meditation that will actually help breathing. But it's something that has to be kind of practiced over a long period of time to really kind of keep you from feeling that sensation on a really regular basis. But most people who do it will find that the frequency of their shortness of breath kind of diminishes over time, that their heart rate and blood pressure is more stable over time when they do it regularly.
Great. Okay. Well, I want to thank everybody for joining us tonight. And Erin, thank you. It's always great to have you around. And nice to have an in-house RT. So we have, let me think, tomorrow is our next mystery diagnosis case that will go up. So there are 2 cases left for the month. And so thank you to everybody that's been participating with that. We are having a lot of fun and we hope you guys are too. Dysautonomia Awareness Month is winding down here. So continue shedding light on dysautonomia. And thank you to everyone for all your support. And this will remain up on our public YouTube page on the DSN channel. And in the next day or 2, I will get it closed captioned as well, so it can be translated. So thank you, everyone. Have a good night. Happy Friday. Enjoy your weekend. And thank you, Erin. So we're going to go ahead and stop broadcasting now. So good night, everyone.